The reason I'm speaking about ECT today is really quite simple. Quite apart from the fact that I'm one of the practitioners of ECT here at Camh, yesterday marked the 80th anniversary, exactly to the day, of the world's first ECT treatment. And accordingly, I felt it was appropriate that we devote some time at Grand Rounds to this. This is actually my 11th Grand Rounds at Camh and its predecessors since 1986, when I did my first one at the former Addiction Research Foundation. And it seems like about every 3 years since, I'm taken out of the vat of formaldehyde in which I otherwise sleep and brought in to give Grand Rounds. The last time Benoit asked me to give Grand Rounds, it was on Shakespeare, Creativity and Madness. And the audience response was such that they said, please bring this guy back in several years. So I'm here today. Now, as you know, at all academic Grand Rounds, we have disclosure statements. Mine is that I have no funding ever from the manufacturers of ECT devices, no funding of any kind from the pharmaceutical industry for more than a quarter century. But like any physician in Ontario, I do receive OHIP remuneration for administering ECT. And I get royalties from my book that has a long chapter about giving ECT. And I also have disclaimers. And for those of you who are unsure about the difference between a disclosure and a disclaimer, disclosure is about conflict of interest. A disclaimer is why you shouldn't even be bothering to listen to this talk in the first place. So my disclaimer is that I'm not a professional historian, unlike people like Ned Shorter, who's written probably the definitive history of ECT. But I am a practitioner of ECT regularly for the last 30 years, and I'm a believer in knowledge of history making us better clinicians. So let me ask you some questions. Too bad Ivan Silver's not here, because Ivan loves audience participation at all these Grand Rounds. So in Ivan's honor, I'm going to ask you a couple of questions. How many of you here, just with a show of hands, recall the first patient you saw undergo a course of ECT? So the majority of people. And in my experience, it's actually quite a clinically memorable encounter for physicians and other health professionals in training. How many of you have referred a patient for ECT in the last year? Hands up. Okay, it's a slightly smaller number. How many of you have administered ECT in the last year? Even smaller. How many of you assess and treat patients with moderate to severe depression? A much larger number. How many of you would want ECT for someone with moderate to severe depression in your own family? Okay. What about in yourself? Okay. Thank you. I make this point just to set a little context for what is about to follow. And what is about to follow is some history that most people in the world are unaware of. Oh, this is not moving. How do I get it to? Ah, there we are. Now, nobody in this room, with the possible exception of our archivist, John Court, will recognize this medical school graduation photograph of Lorne Proctor. Why should you care about Lorne Proctor? Lorne Proctor was a Toronto physician, psychiatrist, born in Victoria in 1908, died in 1986, did his medical school at U of T, graduating in 1938, got his diploma in psychiatry from the University of Toronto in 1941, and was the director of the Rockefeller Research Unit in clinical psychiatry at the Toronto Psychiatric Hospital, which was the forerunner to the Clark Institute. He was in that position from 1940 to 1948. He got more than $100,000 in funding from the Rockefeller Foundation, and it was largely for shock therapies, convulsive therapies involving ECT, insulin, and cardiazol. At the same time, because people multitasked in those days in ways we don't now, he was the medical staff and director of fever therapy and venereal disease clinics at Toronto Western, and also had a busy private practice in neurology and psychiatry. He started publishing clinical and physiological observations on ECT in the American Journal of Psychiatry in 1943. That's when our predecessor started writing about ECT, and he was actually assistant editor of the American Journal of Psychiatry when Clarence Farrar, also of Toronto, was the editor. By 1945, he published in the Canadian Medical Association Journal this article on indications for shock therapy in mental illness, and he was referring to both chemical convulsive therapy and ECT. And he points out in this article that ECT was given in Toronto for the first time in 1941. So 3 years after ECT was first discovered as a treatment, it was given in Toronto, which makes Toronto probably the first place in Canada where ECT was given. Because previously it was said that the first ECT was given in Nova Scotia, but I found out that that didn't occur till 1942, and clearly Proctor was doing it in 1941. He describes back in 1945 the option of giving people barbiturates prior to ECT if they're anxious, because otherwise people were not anesthetized, and recommended it be given 3 times a week for 6 to 8 treatments. And he said if people didn't get better after 5 ECTs, the likelihood of their response went down. And he said the ideal case of somebody who would benefit from ECT was somebody with depression with a minimum of anxiety. So more classical endogenous depression. He reported a response rate in 1945 of 80% for depression, which is basically where we are almost 80 years later. He said the benefits in schizophrenia are usually only transient unless the person has schizoaffective disorder or catatonic schizophrenia and they haven't been ill for more than 6 months. So those acute onset cases with catatonic and affective symptoms, that predicted an ECT response. Again, clinical observation and knowledge that has been revalidated repeatedly over the subsequent 75 years. He said the contraindications were a damaged cardiovascular system or active infection. And with regard to complications, he noted compression fractures of vertebrae were a risk, but in the 400 patients that he summarized in his 1945 article who'd been treated in Toronto, there has been less than 1% of them who've had fractures, and though none of the fractures have been of clinical significance, only radiological significance, so he felt there was no need for muscle relaxation. Obviously, things have evolved. But he pointed out remission rates go down as duration of illness goes up. He also concluded that ECT should be considered only as an adjunct to the well-established conservative psychiatric techniques, with psychotherapy as the fundamental implement in helping our mentally ill. ECT is therefore not a cure, and in my opinion, of limited therapeutic value alone. So he saw ECT as being situated in a much larger context of what we do to help patients. Now, I showed you Lorne Proctor when he graduated from medical school with his little Clark Gable aquiline mustache. Here he is later towards the end of his career. By 1955, he had moved to Detroit, became the chair of neurology and psychiatry at the Henry Ford Hospital in Detroit, a consultant to NASA, the Air Force, and was still publishing by 1961. And shortly after that, I think his career was essentially over. But I had a brutal time tracking down any information about the whereabouts of Lorne Proctor, and was helped by the archivist at the American Medical Association and at the Henry Ford Hospitals, who dug into their files. I want to point out to you that ECT remains a rare treatment. It remains a rare treatment around the world. And the latest meta-analysis on the prevalence of ECT use since 1973 comes from Alain Lesage at the Université de Montréal, who did a large meta-analysis showing that a mean of 17 per 100,000 people get ECT on an annual basis around the world, but that the numbers vary widely from country to country. And he concludes that ECT remains a very rare treatment, even for people with depression and schizophrenia. And there's lots more I could tell you about the variability of ECT around the world, but I'm not sure how gripping it would be. Now here's a face that will be familiar to a handful of people. Who knows who this guy is? Two people. This is Max Fink. Max Fink was born in Vienna, came to the United States in 1924, trained in neurology, psychiatry, and psychoanalysis, and was the founder of the journal Convulsive Therapy, now known as the Journal of ECT, and a champion of ECT. Max is now 95 years old. He continues to publish in the peer-reviewed academic literature. And I can tell you that if you email Max, as I do from time to time, he answers in about an hour. It's faster than LensCrafters to hear back from Max Fink. And he continues to have fun. So he emailed me last year about what he remembered about Meduna's observations about the induction of seizures with chemicals at the Hungarian Neurological Institute in Budapest. And he points out that his institute had tens of thousands of brains, thanks to Emperor Franz Joseph's edict that all deaths had to be autopsied. And this provided the Austro-Hungarian Empire with a large collection of post-mortem brains for study. And Meduna made observations that turned out to be incorrect about differences between the brains of people with epilepsy and the brains of people with schizophrenia. That led to the use, development and use of convulsive therapy. But the ECT story really starts with this man. This is not Bela Lugosi from the early Dracula films, although he looks to me exactly like Bela Lugosi. This is Ugo Cerletti, who was probably the leading psychiatrist in Italy in the 1930s, head of the Neuropsychiatric Institute in Rome. He had quite a distinguished pedigree. He himself had graduated from the University of Rome in 1901, and then had studied with various luminaries, including Kraepelin, Alzheimer, and Nissl of the Nissl staining technique. And he served in World War I, this is the coolest thing, as a mountaineer in World War I. And he's the guy who invented the white camouflage suit for mountaineers. So these guys, they disappeared into the snow in the Alps in their white suits, except for their guns. He also invented a delayed time fuse for bombs, which dramatically reduced the mortality of the soldiers whose job it was to light the fuse, because they had time to get away. Now, he was interested in convulsive therapies, but wanted to find something safer than chemical convulsive therapy with insulin or cardiazol. And he designated one of his research assistants, the guy on the far right, Lucio Bini, to do experiments on animals using electrical stimuli to induce convulsions in animals. So he worked on animals for a long time before he found a safe method of inducing seizures. And then, April 11th, 1938, this is the room where, under a certain degree of secrecy, the first ECT in the world was administered, and that was the machine that was used for that treatment. Now, as you know, here at Camh, we're involved not only in administering ECT, but other convulsive treatments like magnetic seizure therapy. So for the sake of completeness, here's what will be an historical photograph of Dr. Sarah Lisenby administering the first magnetic seizure therapy treatment in Switzerland in 2000. Let me tell you about the first patient in the world who ever had ECT. A 39-year-old male, an engineer from Milan, was found wandering in the Rome train station, unable to provide any information about himself, about his family. He was in fact incoherent. He was speaking gibberish that no one could understand, and then he would at times become mute and then appeared delirious. He was observed in the brought to the hospital and observed there for several weeks. And then ultimately it was decided for him that he would be patient zero in the history of ECT. And new details about his first treatment have emerged from the book Shock Therapy, A History of Electroconvulsive Treatment in Mental Illness, written by our own Professor Ned Shorter and by David Healy. And it is the most comprehensive history I've found of ECT. This book, which is a gripping read, is dedicated to the small band of European émigrés, Italians, Germans, and Austrians, and Jews for the most part, who saw the merits of ECT and sustained its use despite professional antipathy and ostracism and public and governmental attacks. They are unacknowledged heroes in the 20th century history of psychiatry. This book is in their memory. And this book concludes with the following sentence. It is hard, in fact, to think of anywhere where the mismatch between rhetoric and reality is as great as in the history of ECT. Medicine is clearly not vacuum sealed against irrationality. So this man is brought into the ECT suite and they give him a stimulus, a bilateral, bitemporal stimulus, and nothing happens. They look at each other and wonder, what do we do next? And so they turned up the energy setting and gave him a second stimulus. He sat up and he spoke not in gibberish, but in very clear Italian. And he said to them, "Attention, another one is murderous." And then he lay back down. And they looked at each other and wondered what to do. And they gave him a third stimulus. And he didn't seize. Now, in the folklore that preceded the book, he did seize, but that's not actually true. So what Shorter and Healy found out was they waited a week, and then they brought him back in, and they gave him a treatment, and he did have a grand mal seizure that lasted 80 seconds, and then they went on to give him a total of 11 treatments, which is pretty much what we do today for an acute course of ECT. This was in April 11th. By May 14th, he wrote a well-composed letter to the doctors outlining his previous psychiatric illness and treatment, expressed his thanks, and he was discharged home to Milan because he could now tell them who his family was. Contact with the family revealed he had had a previous psychotic episode the year before, unbeknownst to the people in Rome, that was treated with chemical convulsive therapy and associated with a full recovery. By 1939, he was back in Milan, back at his previous job, but in 1940, he had a relapse. And that's where our knowledge of his story kind of ends. But by then, the wheels are in motion. In 1939, and remember, this is just on the cusp of the World War II's outbreak, when Italy would find itself relatively isolated from the West. By 1939, ECT was in use in Switzerland, and they basically had to reverse engineer one machine that they'd gotten out of Italy to figure out how to build new ECT machines. In Britain, it also started being used in 1939. In Buenos Aires, it was used in 1939. By 1940, Denmark and Sweden, 1941, France. And in the United States, the first demonstration of ECT was in Chicago in January of 1940. And then by May, it's actually featured at the American Psychiatric Association annual meeting. And it rapidly, dramatically starts to spread around the world. And remember the context. The context is a time when there are no effective medications for the treatments of psychiatric illnesses. By 1940, so 2 years after ECT is invented, curare, the muscle relaxant, is introduced to try to reduce the risk of bone fractures. By 1942, unilateral ECT is developed. By 1945, they're giving barbiturate anesthesia to reduce pre-ECT fear and post-ECT confusion. By 1951, succinylcholine, the drug we use every day in ECT for muscle relaxation, is invented and used in ECT. So today is Thursday. 2 days ago was my regular Tuesday shift in the ECT clinic. We treated 21 patients in the morning, plus saw patients for consultation around ECT, and that is a typical day in Canada's largest and busiest ECT service. But I remind you, every single general hospital in Toronto offers ECT as part of its range of psychiatric treatments. What do we know about ECT at Camh from the most recent available data from the 2016 annual ECT report? The percentage of patients seen annually at Camh who receive ECT is 0.8%. It is a tiny tranche of the many people we help in a variety of ways. And I can tell you there were 1,500 right unilateral ECTs, 2,400 bilateral ECTs. The gender split is 102 men, 145 women. Mean age of people is in their mid-50s, and the principal diagnosis is mood disorders, but there is a substantial subset of people with schizophrenia and schizoaffective disorders. And from our own ECT report, why are people getting ECT? Well, the commonest indications are failure of our drugs to help them or previous good response. And for anyone who assumes that people are predominantly being given ECT against their will, 70% of the people who receive ECT at Camh are voluntary, and 74% of them are capable of providing their own consent for ECT, and that is who provides it. What are our outcomes like at Camh? Well, we use a relatively crude clinical global impression, and we struggle on the ECT service to get clinicians to complete this form. If you are going to order ECT for your patients, I would encourage you to evaluate their outcome. It seems like a minimum expectation. It takes a couple of nanoseconds to fill out the form. Please do so. But from the data that we have, the people who are rated as much or very much improved amounts to 80%. And that 80% is exactly what Lorne Proctor wrote in 1945 as the outcome. What about cognitive impairment, the thing that we worry about the most with ECT? Well, again, looking at the CGI ratings, none was given to a quarter of the sample. No cognitive impairment. What about cognitive impairment that is there but does not significantly interfere with functioning? 61%. What about cognitive impairment that significantly interferes with functioning? 15%. And what about cognitive impairment that outweighs the therapeutic benefits? 2%. We also have data. Tyler Castor, standing at the back of the room, published a paper last year on outcome in people with schizophrenia who are treated with ECT. We see on the ECT service a number of people for whom even drugs such as clozapine are not doing enough to help those individuals. And the Camh data suggests a robust response to ECT. And I can tell you, we've seen people on the ECT service who have schizophrenia for whom ECT is one of the significant contributors to those people being able to live and to function outside the hospital even after many years of being inpatients. So that's the good news. Now let me talk a little bit about the vilification of ECT, which is almost as old as its discovery as a treatment and is ongoing. Somebody who clearly had too much time on his hands did a study of depictions of ECT in 21st century film and television, looking just at stuff between 2000 and 2014. This is a published study. I can provide the references for anybody who wants them. And found 39 ECT scenes depicted between 2000 and 2014. 1/4 of them in this modern era show ECT as a means of punishment, torture, and murder. The clinical indications are depression, schizophrenia, schizoaffective disorder, dissociative identity disorder, as well as purposeful induction of amnesia 6 times. So the goal was to wipe out somebody's memory. In these depictions, usually given by doctors and nurses, but also by family members, ghosts, other patients, and nuns. Nuns being too many. Now, it's only voluntary in 1/3 of these cinematic depictions. So in a mirror image of the reality, anesthesia was given only in 18% of these depictions, muscle relaxants in 13%. And of course, Camh's reality would be 100% and 100%. Only 3 of the 39 depicted all the essential features of modern ECT. 2 out of 39 depictions showed ECT to be fatal. People died as a direct result of ECT. Fortunately, thanks to the work of Daniel Bloomberger and Paul Kurdiak and the ISIS database, we have information on mortality associated with ECT in the province of Ontario. And this is a substantial review that they published last year, and the mortality rate was 1 in 10,000 people died within 7 days of having received an ECT. 1 in 10,000. And similarly, last year, a worldwide systematic review and meta-analysis of more than 700,000 ECTs, their mortality rate in that study was 2 per 100,000, which is actually lower than the mortality rate for general anesthesia in general. Now, there's another survey that I can tell you about with regard to international movies and television shows published in 2016 that found 82 scenes of ECT, and this is from movies around the world, from India, from Turkey, from Russia, as well as from the West. And the first known portrayal of ECT was in a movie from 1948 called The Snake Pit with Olivia de Havilland. It's often on Turner Classic Movies. It's worth watching. By the 1960s and 70s, ECT was mainly depicted as a form of punishment or social control. The first realistic portrayal of ECT in a film was 1971. Now, this gives you a bit of a sense of how those depictions play out, and you can see how low things like consent are in cinematic depictions of ECT, and given for all kinds of reasons. Similarly, you can see that anesthesia is relatively low in these depictions. I've obtained some actual movie posters that I want you to see. This is from a 1964 film called Shock Treatment. You won't be the same when you come out of shock treatment. But this poster was so powerful, and this was big movie stars, Carol Lindley, Roddy McDowall, Lorne Proctor as the psychiatrist. But this is not my favorite version of this poster. This one is, because it tells you about the characters, and I'll read it to you. The faker, if they caught him, he'd get a shock that would blast his insides. The sex haunted, another classic indication for ECT. Her uncontrollable desires could make her a pawn of the next man. The psycho, on the loose and after strange kicks. The doctor, she used the treatment as a weapon. But the iconic depiction of ECT that has shaped multiple generations is Jack Nicholson in One Flew Over the Cuckoo's Nest. And as I always remind public audiences, because this is the image they know, to remember 4 things about this amazing film, and it is an amazing film. Number 1, the character he plays, Randall McMurphy, was not mentally ill. He was hiding out from the cops in a forensic hospital. Number 2, he got ECT as punishment for bad behavior from Nurse Ratched. Number 3, there was no consent or anything like that. There was also, by the way, no anesthesia, no muscle relaxant. And number 4, he was never the same again. He was a ghost figure after his ECT. Now, in the book, which is superior to the film, he actually has psychosurgery after he has ECT. But that's not depicted in the film. In the film, it is simply the fact that he's had ECT that has reduced him to vacancy. Why is it important? It's important to talk about ECT in terms of cultural perceptions because our patients are coming with those apprehensions and understandable fears when they get ECT for the first time. But it's not just them. It's health professionals. And there's lots of research on the impact of ECT in the movies on medical students. And it is generally negative. We are as sensitive to the barometric pressure of culture as clinicians as the general public. And that constitutes a significant barrier to people getting the treatment they need. Now, there are other barriers, and we experience this quite significantly here at Camh. There is no barrier. If you're a patient within Camh, I defy you to find another service outside the emergency room that will see you, if you're an inpatient, within 1 to 2 days. And if you need ECT, you will start it within 1 to 2 days. That is rapid access to service. But we know that there are hospitals that maintain waiting lists for people to be treated with ECT. Now, frankly, if you need ECT, you can't be on a waiting list. You are at a severe stage in the course of an illness that requires immediate intervention. Nick Delva, formerly the chair of psychiatry in Halifax, did a national survey of 1,200 hospitals looking at who provides ECT. And what he found out is that 84% of Canadians live within a 1-hour drive of ECT. But I can tell you that living near an ECT facility is nowhere the same as having access to it. We provide here outpatient maintenance ECT for patients who've had acute care inpatient ECT in a number of other downtown hospitals, but they do not have the capacity to continue a helpful treatment once somebody's well enough to be outside the hospital. I'm not going to say a lot about the evidence for the benefits of ECT because that's really a whole separate lecture. And similarly, what the theories are about how ECT works. And I say theories because until we know what the cause of depression is, we cannot say how ECT works, how antidepressants work, or how psychotherapy works. We can say what these treatments do, but that may not be how they work. And the history of medicine is characterized by treatment leapfrogging ahead of understanding. The simplest example is aspirin. People knew for 100 years that aspirin took away a headache before prostaglandins were discovered as a chemical. And even then, it may not be the mechanism of action by which aspirin relieves pain. We do know, in terms of the metric of numbers needed to treat, that ECT is an outlier in all of medicine. And the concept of numbers needed to treat is how many people need to have treatment X for one person to benefit. Now, it's a horrible number to think about because none of us like to think that we're giving treatments to people and they're not going to benefit from them. But to give you an example, lots of people take aspirin to prevent a heart attack or a stroke. So 2,000 people would have to take aspirin for a year for one person to be prevented from having a non-fatal heart attack. 3,000 people have to take aspirin for a year for one person to have prevented a non-fatal stroke. And the numbers for statins, Lipitor and others, are not great. But if we look at the numbers needed to treat for treatment-resistant depression, and we know, all of us who treat depression, that treatment-resistant depression is actually more common than people care to acknowledge. The numbers needed to treat with ECT for treatment-resistant depression is 2. You will be very hard-pressed to find treatments in all of medicine that have a numbers needed to treat as low as 2. We know that ECT dramatically reduces readmission rates to hospital and yet remains underused. In fact, Harold Sackheim, one of the leaders in ECT in the United States, wrote last year, "No treatment, pharmacological or otherwise, has matched ECT in speed or likelihood of remission of major depressive episodes. It's equally effective in unipolar and bipolar depression, has profound anti-manic properties, and yet it is underused." And I've done surveys, national surveys in 1990 and 2000, and I'm going to hand the mantle to Daphne Vanescus to do the next round of this survey, looking at resident training in ECT. And I checked with Mark Pfeffergrad, and it's still a requirement. And here we are, the largest training program in North America in psychiatry. And I would flatly say our residents are undertrained in ECT. And here's the irony. It's our single most effective treatment in all of psychiatry and for our most severely ill population. It would be like training cardiologists and saying, we're going to train you to treat congestive heart failure, but not acute pulmonary edema. You don't have to know that because you'll have an outpatient practice. All right? That would be completely untenable. Oh, that's Olivia de Havilland, who I think is still alive, in the snake pit. You can see she's looking pretty relaxed here as she anticipates having her first ECT treatment. But this was the first time people saw ECT on the silver screen. I'm going to skip through all these slides about education. This appeared this month in Lancet Psychiatry, a terrific journal, ECT and brain damage. Does electroconvulsive therapy damage the brain? Still an open question 80 years later. Anti-psychiatry, anti-ECT people will tell you yes, unequivocally, it does damage the brain. I would say that the evidence is more equivocal than that, and we know lots about the impact now of untreated depression on brain structure, brain function. And this latest study looking at whether ECT increased a risk for dementia, particularly in older people, was quite conclusive that it did not. So I'm going to conclude, because it's 10 to 1 and I'm supposed to. I'm going to conclude by saying that I hope that both research and serendipity are going to generate treatments with even greater benefit and less toxicity than ECT currently provides, because our patients and their families deserve no less. And Camh is very well positioned through the Temerty Center to continue the research that was initiated about 75 years ago by Lorne Proctor at one of the predecessor hospitals to Camh. But until that day happens, and we'll be launching shortly the randomized trial of magnetic seizure therapy versus electroconvulsive therapy here at the Temerty Center. Until that happens, until we have better treatments, we need to be defenders of what works in our clinical care. We need to be defenders of it in our teaching and in our advocacy. And finally, we need to know our history, both scientific and cultural. Thank you. I mean, you know, I've seen, for instance, in the community of Windsor, they stopped doing ECT several years ago. They'd had a bit of a screw up. I don't mean involving patient care. I mean on the administrative side, they'd had a bit of a screw up, and suddenly ECT became unavailable for several years. We had patients driving in from Windsor to Toronto to have ECT. They have gotten their act together. They have enhanced their ECT service, and I see this happening in other settings as well. And part of the reason is huge pressure on beds and the readmission reality. You know, when I ask people in the States, in American audiences, where do you think ECT is more common, in state hospitals or private hospitals? Many people assume it would be in state hospitals. Wrong. It's way more common in private hospitals. Why? It's very expensive to be in a private hospital. People need to get better quickly and get out. Now, I can tell you that clinical practice guidelines for the treatment of depression, a survey of all clinical practice guidelines for depression released this month, looking at 12 of them around the world, 11 of the 12 recommend ECT as a first-line treatment. And one of the things I remember about one of the guidelines said ECT should be considered as a first-line treatment when the rapid relief of symptoms is required. I thought, so when is the leisurely relief of symptoms required? But obviously, in our current climate, most people will say they're going to start an antidepressant before they start with ECT. We see cases where ECT, the person who stopped eating, stopped sleeping, is catatonic or psychotic, and we, in those circumstances, will go straight to ECT. But more commonly, people journey through a sequence of treatments and combinations of treatments for which the evidence base is way lower than ECT before they get to ECT. So I think we need to be advocates for it, and systems within hospitals need to change to make outpatient ECT more available, because the vast majority of people treated at CAMH are outpatients who go home after their treatment, not who have to wait to be admitted in order to get this treatment. California came very close to outlawing ECT a couple of decades ago. And there have been movements in Ontario to have ECT banned. These efforts have occurred around the Western world. And every time they have occurred, there's been pushback and ECT has been preserved. But you still face an uphill battle. And some of it even comes from our medical colleagues who are stunned to find out that ECT is still given. They think of it as an outmoded historical relic until they have a family member who gets better with it. Well, the question was, if ketamine trials get more successful, is there a possibility that they would replace ECT? Interesting, there was a recent ECT trial involving giving people ketamine as well. That was not particularly impressive in its results. And the ketamine story is, I think, still yet to be written. There's a very good recent editorial by Charles Nemiroff about some of the problems with the ketamine research to date. Look, I'm hopeful that anything is going to come along that works better than ECT. And I don't have a romantic attachment to ECT. I will drop it like a hot potato if something comes along that's better. It's a sad reflection on progress in our field that a treatment that is 80 years old continues to outperform our more recent interventions. But we can't jettison it, or me, just on the basis of age. So the question is it safe with cognitive impairment in the elderly? And the answer would be yes, but, right? So the yes is that we might be inclined to use ultra-brief ECT, the most cognitively sparing form of ECT, which is how most patients at CAMH start ECT. Right unilateral ultra-brief treatment in an effort to minimize cognitive impact while still obtaining benefit. And if patients don't respond, then we'll progress to other forms of stimulation. But remember, one of the challenges is that, particularly in the elderly, depression can often be accompanied by pseudo-dementia. And so you may see enhancement of cognition in some patients. And again, with depression, even at a younger age, that it has an adverse, erosive impact on concentration, on memory. The alleviation of depression can be associated with improvements in those cognitive domains.